on behalf of Boston Scientific to this noontime session where we will present information on the potential use of bronchial thermoplasty as a new treatment, one that represents a paradigm shift in our thinking about how we can help our patients with severe asthma. I'm Gerard Cox from McMaster University in Hamilton, and I've had the privilege of being involved with this work from the time that it was conceived as an idea in the laboratory, used in preclinical models, and then I've contributed to the clinical studies that have been completed. I'm joined this afternoon by a college of internationally renowned researchers and clinicians in respiratory medicine and specifically in asthma. I'll be followed to the podium by Michael Weschler, Professor of Medicine, currently based in the Division of Pulmonary and Critical Care Medicine at the National Jewish Hospital in Denver, who's been an essential colleague in the use of this technology in the United States of America and in the completion of our trials here. Ian Pavord will follow, who is Professor of Medicine based in Leicester, UK. Ian has been a key member of the investigating team, a treating physician, and his centre has enrolled patients in the trials of bronchial thermoplasty that have been completed. And we will finish with Professor Felix Hirth, who can do just about anything with a bronchoscope that needs to be done, including bronchial thermoplasty. He's introduced the technology and technique in his native Germany, and he's based in the University of Heidelberg in Germany. So without further ado, we'll carry on. You know that severe asthma represents a major challenge to us and to our patients. The prevalence of severe asthma varies among large studies, but it's somewhere between 5 and 10% of the asthma population. And these patients have troublesome disease that we have difficulty controlling with currently available medications. The other feature that we always hear at meetings about managing severe asthma better are issues around compliance and concerns around toxicity of the medications we prescribe. These concerns bedevil our efforts to take care of our patients' disease better and seriously impact our patients' quality of life and their health. This illness is associated with high utilization of healthcare resources and also with high losses to our patients from their productivity as members of society at their homes and also at their places of work. And into this arena, we now introduce the possibility of using a new technology, bronchial thermoplasty, that may be available for us to use in treating our patients. There's been quite a broad uptake of bronchial thermoplasty across the world. It's currently available in 23 different countries and at some 280 different sites. There are over 550 trained physicians who are capable of providing this clinical service now, and among them have treated over 1,500 patients with over 4,500 individual procedures performed already. So this is quite a marked growth over and beyond the experience that was published in the clinical trials. I'll hand over to my friend and colleague, Dr. Michael Weschler. I should have said that all questions will be entertained at the end of the formal presentations.
Thank you. It's a pleasure to be here. I'm excited to present today some data regarding the effects of bronchial thermoplasty. And now we have data out to 5 years from the pivotal AIR2 trial, and we'll be presenting those data tomorrow at a poster session. So the AIR2 study was an important sham-controlled double-blind study done to evaluate the safety and efficacy of bronchial thermoplasty in patients with severe asthma. The data were published a few years ago by Mario Castro in the American Journal of Respiratory Critical Care Medicine. And in that manuscript, the key findings after 1 year demonstrated that there was an improved asthma-related quality of life compared to the sham group. Approximately 4 out of 5 patients who received bronchial thermoplasty achieved an improvement in the asthma quality of life questionnaire score. And this effect persisted at 6, 9, and 12 months. More importantly, I feel, was the benefits that were seen with bronchial thermoplasty with related to other outcomes. In specific, there was a 32% decrease in severe exacerbations. There was an 84% reduction in the emergency room visits for respiratory symptoms, a 73% reduction for hospitalizations for respiratory symptoms, and 66% fewer days lost from work, school, and other activities. And this is all compared to the sham group. There were no unanticipated device-related adverse events or deaths, and therefore there was a very acceptable safety profile. We sought to follow these patients who underwent bronchial thermoplasty for 5 years to assess the overall durability of effect, to see how patients did over not just the 1-year period, but to see whether or not there was a durable beneficial clinical effect and whether or not there was durability in terms of the long-term safety of this procedure. And we hypothesized that the patients who received bronchial thermoplasty would be just as good between years 2 and 5 as they were after 1 year. The primary endpoint that we examined was the proportion of subjects experiencing severe exacerbations in each of the subsequent 12-month periods of time out to 5 years. And we also examined emergency room visits, hospitalizations, respiratory adverse events, and we looked at lung function as well. At 2 years of data, a 2-year time point following bronchial thermoplasty, the data was published 2 years ago by Mario Castrogan in the Annals of Allergy, Asthma, and Immunology. And what was demonstrated was that bronchial thermoplasty was effective at a 2-year time point, just as it was after 1 year. In this slide, we can see the effectiveness of bronchial thermoplasty in terms of the proportion of patients experiencing severe exacerbation between years 1 and 2. At baseline, there were 288 patients, 2/3 of whom were randomized to receive bronchial thermoplasty, 1/3 of whom was randomized to receive sham bronchial thermoplasty. At the end of 1 year, the relative exacerbation rate, the proportion of patients experiencing severe exacerbations, was significantly reduced down to 31%. And this improvement in terms of reduction in severe exacerbations was maintained out to 2 years, with only 23% of individuals experiencing severe exacerbations. So at the end of 2 years, there was over a 50% reduction in terms of the percentage of patients experiencing severe exacerbations. We followed patients out from 1 year to 2 years to 3 years, out to 5 years. And what was remarkable was the significant retention rate of these subjects who participated in the trial. There were 181 patients who were followed at the end of 1 year, and over the course of the subsequent 4 years, there were still 162 patients. So from the original cohort, over 85%. Now for clinical trials, particularly asthma clinical trials, 85% retention is extremely high for a 1-year study. And over a 5-year period of time, it's extremely, extremely high. And if you consider the patients who entered the long-term run-up, those 181 patients at the end of 1 year, almost a 90% retention of subjects, which is remarkable. And I think it bespeaks the relative durability of the effect, which I'll show you in the coming slides. At baseline, patients who completed the 5 years versus those who didn't complete the 5 years, you can see there were 28 patients who dropped out. They were relatively comparable in terms of age, in terms of inhaled corticosteroid dose, in terms of lung function, about 78% are predicted, in terms of percent symptom-free days, in terms of baseline asthma quality of life questionnaire. Interestingly, the patients who completed the follow-up, there were 10 hospitalizations in 8 subjects in the patients who did the 5-year follow-up versus no hospitalization in those who didn't complete the follow-up, suggesting that those patients may have actually been even more severe and may have been a bit more responsive than the other patients. In terms of emergency room visits, about 29% had experienced emergency room visits. In terms of steroid pulses, 53% in the 5-year completers versus 43% in the 5-year non-completers. And they had similar rates of seasonal allergies. And this is where the data, I think, is really exciting. We examined the severe exacerbation rate. We can see on the left-hand panel is the percentage of patients who have severe exacerbations. And we examine them in the 12 months before bronchial thermoplasty, at 1 year following bronchial thermoplasty, and then at 2, 3, 4, and 5 years. And you can see, compared to the 1 year before bronchial thermoplasty, the significant reduction in the proportion of patients who had exacerbations. In sum, you can see that over 50% of patients had severe exacerbations in the year before. And if you aggregate the data over the 5-year period of time, it was less than 30%. So there was an over 40% reduction in the proportion of patients who had severe exacerbations after bronchial thermoplasty. On the right-hand panel, you can see the rates of severe exacerbations in terms of the number of events per subject per year. You can see that in the year prior to bronchial thermoplasty, there were approximately 0.9 events per subject per year. And then over the course of the subsequent years, you can see at the end of year 1, that rate dropped by almost 50% to about 0.5 events per subject per year. And that rate remained relatively stable between 0.3 and 0.55 events per year, with a mean close to around 0.5 events per subject per year. So again, you see a very significant reduction in terms of the rates of severe, decrease in terms of the rates of severe exacerbations per subject per year, which I think is very exciting. We also examined emergency room visits for respiratory symptoms. On the left-hand side are the proportion of subjects with emergency room visits for respiratory symptoms in each year, and the right-hand panel are the rates of emergency room in terms of events per subject per year. Similar to what was seen with exacerbations, you can see that there's a very significant reduction that was maintained over a 5-year period of time in terms of the percentage of patients who had emergency room visits every year, and also the rates in terms of events per subject per year. It was also significantly reduced and maintained over a 5-year period. I think this and the prior slide really demonstrate the durability of effect of this therapy. Another important aspect was whether or not there were changes in lung function. People had concerns early on that perhaps by ablating airway smooth muscle that there might be some potential deleterious effect in terms of lung function. And we see here, both in terms of both pre-bronchodilator FEV1 in blue, as well as post-bronchodilator FEV1 in red, that there is sustained benefit in terms of FEV1 over the 5-year period. There's no significant decrease in terms of FEV1 over the 5-year period. In terms of safety, over the 5-year period following bronchial thermoplasty, there were no increase in proportion of subjects experiencing any respiratory adverse events. There were no increases in rates of any respiratory adverse events. There was no increase in the proportion of subjects experiencing adverse events related or unrelated to asthma, nor in the rates of asthma adverse events specifically in terms of multiple symptoms of asthma. And there were no serious procedure-related complications, nor any unanticipated related adverse events over the course of the 5 years. And as I mentioned, pre-bronchodilator FEV1 remained stable, and the response to bronchodilator was maintained. All these are important factors which I think bespeak the relative safety on top of the efficacy of this therapy over a 5-year period of time. So in sum, based on these data, bronchial thermoplasty seems to have emerged as an important addition to our treatment armamentarium for patients with severe persistent asthma who remain symptomatic despite inhaled corticosteroids and long-acting bronchodilator therapy. Bronchial thermoplasty with the AIR system has been shown to provide durable asthma control out to at least 5 years in patients treated with this therapy who have severe persistent asthma. And the safety of bronchial thermoplasty in asthma also persists out to 5 years. And the reduced need of urgent care visits, fewer exacerbations and ER visits following bronchial thermoplasty, I think meets the goals of asthma control specified by the NAPPP as well as the objectives of healthcare reform. This is a beneficial therapy that is safe and effective and durable out to 5 years of time. Thank you very much.